We're going to have a nice, lovely discussion on what to do when you can't oxygenate a premature infant. This is something that obviously is very pertinent to pediatrics because, well, we deal with this stuff quite frequently. We have Dr. Manzar, who is one of our neonatologists, who's going to be talking to us today. So, Dr. Manzar, go ahead.
Thank you so much. So, we'll start. I think you guys have guessed what I'm going to talk about. So, I have no disclosure. And no conflict of interest, but I do have the following disclosure, that this presentation has been approved for an appropriate audience and is unrestricted. You can do whatever you want, but there will be a strong language content, knowledge content in that. So these are the objectives. I'm going to just talk about and go through the whole presentation about different aspects of hypoxemia, and we'll come back to this slide again. So oxygen, as we know, if you go under the sea, if you go high up in the sky, you need it. So that's why this topic is pertinent to all of us. So apology to Tucker. I don't know if he's here. Last time he said, but I think we have to modify it. I think we need Wi-Fi is something that's what we need more than anything else. When I was a fellow and I was asked to give a talk on respiratory distress, I said, you know what, I went ahead, hypoxemia, respiratory distress combined, the topic is respiratory distress syndrome. I said, let's do this time as well. So I said, I'll do a Google search and see where we are. And guess what? These are the slide presentations already available for you guys to review. So what I'm going to teach now, it's difficult. So can you imagine you can do any topic presentation, you just go to Google, and you have 60 slide presentation by excellent professors with everything down there. So I will try to make it interesting so that you guys are engaged and try to learn from each other. So again, these are the outline of the discussion is going to be, and again, we'll come back to this. So this is the case I'm going to talk about today. So the pertinent information is this is a premature baby, 35-weeker. Nothing is positive except for HSV. And these three diseases are positive in the mother. And again, at delivery, there was no spontaneous cry, baby was a little depressed. But look at this. Very interestingly, the Apgar score at 10 minutes was 9 and the cord pH was good. And why did I write this good, bad, and ugly? Because if you work with obstetrician, this is the movie you're going to face all the time. Who is ugly, who is good, who is bad. So you have to come like Clint Eastwood and do that. But the point which I want to make in this slide is that this baby, despite of being depressed, look at the Apgar score. So Apgar score is not a predictor to do the resuscitation or guess that how the baby is going to do in terms of hypoxemia or distress or need for oxygen. Just a point to take home. Case, again, you see that this baby was appropriate for gestational age. All parameters are okay, and essentially except for little desaturation, everything looks okay. On physical exam, the only pertinent finding was the heart pulse was displaced to the right, and there was some tachypnea, there was some lethargy, and visible cyanosis, but again, that was not classic. So this is the text which I was hearing that they are doing, that what's wrong with your baby cousin? Blue. Oh, I think he has a broken heart. So I think if we could have fixed it easily, then we should be doing WebMD and we should all be good. So is it that easy? Probably yes. Probably the baby has some heart condition, but again, we are medical students, so we have to learn and go through the differential diagnosis. So again, the case summary, premature, 35-weeker. The only pertinent finding is the pulse noted on the right side and the retraction and some cyanosis. So what's wrong with the baby? Any takers? Any emoticon generation, that broken heart, blue or something? Anyway, so either it could be lung, it could be heart, or it could be the hemoglobin. So let's walk through it together. So what happened, when we know that oxygen just comes in, goes to the red cell, from red cell it goes to the tissue, and here all the metabolic processes happens. So this is the oxygen cascade. Just remember, whatever comes to the alveoli, very minimal goes to the mitochondria. If you don't remember this slide, just remember your salary. It just goes after first month, and this is your salary, what happens to it? You start with this, and 30th of month, you have this one remaining. So again, reiterate on the same concept. See, we start with 150, 100, 95, 40. So you got the concept that how the oxygen, what is coming to the alveoli, almost 60% is gone. And this is few definitions which I have seen that my students and residents struggle with. So let's look at it. So PaO2, SaO2, SpO2, CO2, you hear it many times, but honestly, if you know the concept, then it's so easy to remember. And the prefix usually with the O2 tells you what it means. But the equation which I want you to remember today is this one, the oxygen content. And again, you can have this slide later on for review. Any question on this slide? Because this slide will have bearing later on. No? Okay. So this is the differential diagnosis I think this baby has, and we'll walk you through later on. So what are the tools we use in an neonate who comes with cyanosis or, in other words, low saturation? These are the diagnostic things which we do. And again, I teach my resident interns that use wisely. Every investigation which you do, you have to be very wise with it. Don't just run the whole panel of tests without thinking. So this is the chest X-ray. The positive finding is you can debate that probably there is not great aeration, and you can see the heart, which is to the right side. Gastric shadow is on the right side as well, and liver is flipped. So what is this condition known as? I was expecting them to say. Okay, so this baby has dextrocardia with situs inversus. And again, another picture, and now you can compare the lung, that after surfactant therapy, look at the expansion in the lung. It is probably you cured the baby. So you expect the baby by now to be saturating in 90s, but baby was not doing that. And this is the blood gas which we got. See, you are giving 100% and your O2 is only 50. Again, with 100% oxygen, the pressure is this. So where is the pressure going? What is happening to the oxygen? Either it's a hypoxemic failure, or there is some ventilation perfusion mismatch. So again, this is a busy slide, but again, if you don't have to remember all this. This is on your phone. If you put oxygenation index, it will take you to the app and you can put your numbers and get it. So you don't have to remember the formulas. Just remember the concept. So basically, again, you start with heavy oxygen here, but only this much is going to the arteries. So something is happening. Either there is some meconium, there is something, some diffusion problem between alveoli and the blood. It could be problem with the alveoli itself, or there is some perfusion problem. And again, like I said, we're going to talk about it in this slide. So what is ventilation perfusion mismatch? So you don't have to remember all 5. Just remember the first square. Either there could be good ventilation, but there is no perfusion. The second option is there is no ventilation, but there is perfusion. And the best option is this one, which is like, and this one you have to probably propose now by a ring and say that you are my best match. So this is what you want, the best ventilation and best perfusion. And again, like I said, you don't have to remember all that. This is again a very important slide, and I think Dr. Pramanik will know that when he was a student and when I was a student, we have like 30 years of gap, but we used to call it persistent fetal circulation. The reason is that you all remember from your basic science. Let me walk you through. So what happened, the oxygenated blood comes, goes to the left side, then you see the PDA, it jumps. So basically, in fetus, you don't need the lungs to function. So lungs are at high resistance. So that's why you don't want it to happen after birth. So what you expect? You expect the lungs to open up, the perfusion to improve, and let's see if it happens. So you see here, this is what you expect. You want the systemic pressure to be higher than the right side pressure or the pulmonary pressure. But what happens when there is some resistance? So what happens is like instead of blood going to that side, the blood just comes back and goes from right to left. So this baby, why this baby is not improving? We have given oxygen, we have given surfactant. Does this baby has this condition, which is the old name, like I said, is persistent fetal circulation, or you can say PPHN. Are you guys with me? So if you can, I hope I haven't confused you yet. So now let's forget about me, or let's ask the artificial intelligence if they can solve this problem. So we'll say to our device, Alexa, baby with low saturation, what should I do? So I hope it plays. Let's see. Okay, it didn't play. Okay, so we'll go ahead. So I hope in future we'll have this thing with Alexa or Siri that you can just say that this is my problem and Alexa or Siri will guide you through. But I think we are here now that we have to learn, relearn. We can do with computer and science, but I think medicine itself is a science. So if you learn it, like I always teach, go to a specialty where the skills are needed. You don't want to be replaced by a robot. So think about it when you select your service specialty. So again, this is like we used to do it in all babies, hyperoxia test, but because of big scale of oxygen and all, we are not doing it anymore, but this is a very nice and easy clinical pathway you can follow. Provide 100%. If PO2 goes above 300, it's probably normal. Between this, if this. So we could have done that rather than going through all the presentation, and we know what the diagnosis is. But trust me, it's like emoticon texting. It's easy on that, but very difficult on the real scenario. So let's see what we can eliminate. RDS, there is no whiteout. I think we should be okay. Pneumothorax, there was no air in the pleural cavity. What about pneumonia? I don't have any history of chorioamnionitis. X-ray looks normal. There is no abnormal CVC. Hemoglobinopathy, there is no history. And hemoglobin, if you guys were vigilant enough, in the gas it shows 40 in hemoglobin. So even quantity-wise, the hemoglobin was okay. So now we are left with these two conditions. Any taker again? I think we go back to that Canadian road pathway that you are still confused which direction to go. And I know there are a few people from Canada, they might feel it bad. But okay, so let's go back again to this. So now we can see, that we remember from the previous slide, or you see it here, that if the FiO2, after giving 100%, if PO2 doesn't go above 100, probably we are dealing with this side, which is probably a cardiac condition. So what should we do to eliminate or to diagnose that? One investigation, echo. So we did that. So we were playing wise here. We are going in direction, choosing wisely what to do. And of course, a baby was on high frequency ventilation, so it's very difficult to really do echoes, and especially with dextrocardia and all, and intubation and all. Anyway, so there was suspicion, and the diagnosis was made, and I'm going to tell you about what this means. So we started the baby, basing that the baby has persistent pulmonary hypertension, because remember, from the previous slide, these are the two diagnoses we are left with. So we started with PPHN, because our echo was showing okay, and we called the ECMO team. Guess what? The repeat echo showed a different finding. Anybody know what this is? Oh, yes. Sorry. So let me walk through it and see if I'm going to make justice with this presentation. Anyway, for me it was a really learning thing, because we all read this in embryology, but the more years you put in, you tend to forget. So there are three areas or dashes which you have to fill. So if you just remember, you have atrial relationship with the viscera, then how the ventricle loops in, and then the position of great vessels. So it's so easy. So these are the three dashes you have to fill in. And again, same thing. So this is orientation. And if it's on the right side, it's soletus. If it's on the left side, it's inversus. So that's easy. Then the way it loops in, if it comes this side, is D loop. If it goes that side, is L loop. And this is a little difficult to understand, But if you just look at here, L is your aorta is anterior and your pulmonary artery is leftward. I know it's very difficult to understand, but just remember that. And if you don't remember the normal is soletus, and soletus is just like your credit card, APR, anterior aorta, APR. Always remember that, posterior and rightward. Okay, I hope you'll not forget that. Anyway, so again, to show the same thing, again the same thing. So finally we made the diagnosis that this baby has this. So this is the normal circulation with no TGA. The body will pump, it goes to the right side, comes back, goes to the left. Easy to understand. But what happened with this baby? This baby was doing like the parallel circulation, which is the hallmark of PGA. So this is the comparison, and I wanted to rush to this slide before Dr. Jones leaves. So this baby, usually if you have LTGA, it's automatically corrected, but unfortunately this baby's right heart was switched. So unfortunately this baby cannot have this blessing. So that's why this baby was going through the parallel circulation. And again, you can have this slide for review, and we can talk about it. We thought that we have diagnosed it, it's all good, we'll send to a referral center and we'll be good. But guess what? We transferred the baby, and this baby had some deletion, a big deletion, and we'll have 2-3 slides on that as well. So now we were worried, is this Cri-du-Chat syndrome, or what is it? Is there an association of dextrocardia and this LGA, TGA with this condition? We don't know. So this is an interesting slide. If you see carefully, with Cri-du syndrome, the deletion is basically terminal. But here in our case, it was not a terminal deletion. So this was not a classic Cri-du-Chat because the deletion was only in the big segment, but the terminal part was intact. So we know that this is not that. And baby was not classically, phenotypically behaving like that syndrome. So we said, let's do some Google search again, going back to the artificial intelligence. We said, let's see how many cases are reported with this type of deletion and this type of condition. So we looked at carefully, we found so many diseases associated with like VSD, PDA, pulmonary atresia, but interestingly, we were unable to find any correlation or any case report with that. This is again to show that congenital heart disease with this deletion has been mapped. Again, the same thing. You see congenital heart disease, you map it up, you see a big segment deletion there. So there was no deletion reported. So guess what? We said, we'll sit together, Dr. Walia, Dr. Jones, and we said, we'll write something on it, and it got published. So now, finally after that, we were able to take the heart out of this presentation. So going back to the emetocon slide, this girl was right. The baby has some heart problem. It was a broken heart. And this baby is doing great. Where's Shahina? You want to tell about the baby? Just one sentence.
Yeah, so the baby's doing well. She's growing. Her growth curve is kind of flatlined, as you would expect, but every time I see her, she's gaining weight. She has an NG tube right now, which isn't ideal because she's about to be 6 months old, so we're putting some weight on her to get her ready for her leaky button, so we can feed her that way. And as her primary care pediatrician right now, we're just getting her immunizations, trying to beef her up a little bit, get her to gain some weight so that we can send her back to New Orleans and see if she can have her atrial switch procedure and maybe give her a little more quality of life. But yeah, her mom loves her. Mom takes great care of her. She's like a little doll every time she comes in.
See, interesting, really. So let's summarize. So basically, we have a preterm baby with cyanosis and desaturation. And again, what's the difference between cyanosis and desaturation? Any bright person can tell me? Because we have time, so let's utilize that. Especially from interns or residents. Anyway, I think in a big audience, people get nervous. So we'll ask in the NICU. And there is a difference between that. Like, you could be desaturating, but you cannot be cyanotic, depending upon your hemoglobin level. Anyway. So this baby had both. Then we talked about how the diffusion from the oxygen all the way to the hemoglobin and how it goes beyond that. We talked about that. We touched a little bit about what is ventilation perfusion mismatch. Lungs can behave differently, the heart can behave differently, and that can cause either PPHN or we already have a case of transposition. What are the diagnostic tools? If I have to choose one investigation in an ICU on a baby who is behaving septic, I'll just go with the blood gas. Always remember, if you don't have anything, just get the blood gas. Blood gas will tell you a lot, and those who has rotated already with us, that how we focus on blood gas. Every batch will try to run this blood gas analysis, how to interpret it, and Paul is excellent in it. So we did that. Okay, the last part is, if you have an interesting case, think of genetics, really. It's like, my son started school this year, and he was telling me that how genetics has changed the whole thing. Epigenetic, they have wristbands now, and they can record your changes in the epigenetic during the course. So we are being monitored. So in conclusion, cardiac disorder should be considered in any unit, and we do it all the time, but trust me, when you are very near to the tree, you miss a sight of the forest. Like, we were working there, the baby was not coming up. You think of a premature baby as RDS, PPHN, these are the most common diagnoses. And again, echo showed, okay, it is not bad, but guess what? It was a cardiac case. So always consider that. And again, like I said, if you can get it early, better. And one day we'll talk about the role of echo in neonatology. We overlook it, but I think we can really use it to its full potential. We just do it to, okay, it's PDA or not, but you can do a functional echo to manage your cases. And again, if you see any atypical, not about cardiac case, but anything which is atypical, obtain a genetic study. And again, if you see that, it's interesting, please write it up. Any questions? Any questions, comments? Yes, sir.
A couple of comments and then a question. You started off very well. It's a very good presentation, a lot of physiology in that, in terms of oxygen transport, and I'm glad you brought that. What matters when we talk of hypoxemia is the mitochondrial oxygenation. We always talk about saturation, you nicely showed the S-shaped curve. Getting back to the patient, if you've got a blue baby, my comment is look at it in three ways. Either it's the lungs, most commonly in a neonate, certainly in a premature baby, or it's a heart, or the pulmonary vasculature, as you nicely showed in Lakshman's slide. He's a good artist on the fetal circulation, or a combination thereof, any of these three. So always approach it from that point of view. It becomes a lot easier. Now, you did talk about the hyperoxia test. I always teach that if you want to use hyperoxia test, make sure there is a cardiologist at the other end of the telephone line, and you have an echo immediately available, because most of these kids don't present in day one, but they present anywhere between day 2 to day 7 and 10. When they've gone home, they come back, somebody in the clinic thinks he's got sepsis. If you give that kid 100% oxygen, and if he's got a ductal dependent lesion, he'll be dead in 2 hours. So you have to have somebody, and not only that, when we give oxygen or when we give prostaglandin, you have to be always ready to intubate and stabilize that kid. I'm sure Nitin would agree on that. But anyway, keep that in the back of your mind. And certainly from a question point of view, the question I had is, nowadays, if I'm not misquoting, the data is that the earlier you do the switch, the better is the outcome. And again, because it's relatively rare, surgical risks, I always say, nowadays medicine has become a business, that the best surgeons and the best cardiologists should be involved right from the beginning, because there are those who've done hundreds of these in their hands. For instance, Little Rock, Arkansas, that's why our fellows used to go there, that their results are fabulous, the top 3 in the country. And so that's very crucial where the patient is being, as pediatrician, budding pediatricians, they have to know those things. And certainly last but not the least, I always teach residents, because we've had, on a few slides, you had ECMO at the bottom. And I still remember this kid on the PICU who came from Japan. They asked me to consult on this kid. And I said, what the heck? So history sometimes the exam doesn't have. But I always say if a patient is not responding to antibiotics, please think of a disease that you can treat, a viral disease, which in this kid unfortunately in my book, died. He had herpes, disseminated herpes. You gave a history of 1 year ago, but it can be recurrent, right? So this kid was about 2 weeks old. He was going down the hill. They had put him on ECMO. He was bleeding. But if you look at the point of teaching for the resident is that if your LFT is way out of proportion, if your PDT is way out of proportion, that kid has herpes unless proven otherwise. So you must put him on acyclovir right away. You always take it off after the cultures are negative. Do you?
So this baby, the initial exam finding, I think it was mainly hypoxia. And the other thing I think which is a teaching point is, we had the X-ray, these near-term baby, we think PPHN is the most common cause. The chest X-ray was done, but whatever was available, it was mainly a chest X-ray. But we picked up the stomach was on the other side. So that's how we started. Okay, let's do an echo. And then baby was remained hypoxic. And so again, the clinical investigation, if something is there, just to be careful. I don't know if cyanosis was the problem.
Exactly.
It was mainly hypoxia in this baby. And our first, the babies we had some C-section or eating. But this baby turned out, had a significant cardiac problem. But baby was very comfortable. Baby was not like in significant distress. So again, EPA babies, they became their problem.
So going back to Dr. Pramani's point, it's a very important point that giving oxygen to babies with cardiac condition. There's only one condition. It's not like all ducted dependent lesion you have to be worried about oxygen. Some you can. Only hypoplastic left heart is the only condition where you don't want to give oxygen because that's the only source by which the baby is getting blood to the systemic circulation. If it's a PDA dependent lesion, but if it's a TGA or if it's something else, that's fine. You can still give oxygen. But only hypoplastic left heart is the condition where you don't want to give that. And there's only one condition where you cannot give PGE, and that is total anomalous venous return. So always remember these two key are from the board question, that if they give you a case which is you think is total anomalous, don't give prostaglandin. If they give you a case with hypoplastic left heart, don't give oxygen. Otherwise, for every heart condition, if you have to pick, start PGA, nobody will blame you. Start oxygen, nobody will blame you. But again, with the advent of having a cardiologist in-house, we have an echo right away. Actually, many places are teaching neonatologists now to do the echo. So actually this morning I was seeing a video that stethoscope is gone now. Now they have the probe you can attach to your cell phone and you can get the real-time echo or real-time whatever. So fantastic. The guy really did that. He took out the stethoscope and he put the probe on his neck. He said that's going to be the future. So he said I can see that. So I think in future, but this is very important, you don't want to go blind. That's why choose wisely. If you have, that's the whole purpose of the talk honestly. That you should think, not just jump on, just order all the tests, and know the difference between different things, like what is cyanosis, what is hypoxia, what is desaturation, what is PaO2, what is SpO2. It's very easy to see on a slide, but I tell you, when you get a question in board, and they try to screw you guys, I tell you, they are going on tier 3 now for the steps. I see these questions and I said, God, this is a step 2. This is not a step 2, this is neonatology question. But that's how they are doing, because they think that you guys know already. So they already know that you have diagnosed it. So now they gave you, oh, this gas is drawn from the arterial line, that's the reason. Or this saturation is reflecting an adult hemoglobin. And now you have to think, I know how to interpret a gas, but I don't know how to interpret SaO2. Just by remembering the saturation curve, you can easily make it out. Anyway, any other questions, comments?
I want one other comment.
Sure.
Very, very important, which is very applicable to everybody in this audience. That as you know, pulse oximetry is the standard of care in every baby who's born. And we do this internationally, that if your saturation on pulse oximeter, which is calibrated, is less than 90%, there's an algorithm that has been done by the American Academy of Pediatrics, American College of Cardiology. There are different versions of it. To make a long story short, if it is 90% times 2 for over an hour, that baby cyanotic heart disease unless proven otherwise. Why am I telling you this? You may be practicing in the boondocks. So everybody's got a pulse oximeter there. And now, what I stated earlier, what we do internationally is we have satellites where these are not even doctors, they are lay people who can transmit that data through the satellite to a level 2 or a level 3 center. Cardiologist looks at it, okay, you can transfer the baby to us. So that is very important, and a lot of credit for this goes to, I wish Dr. Bocchini was here because he sits on the committee of screening for different neonatal diseases, that this has become universal today, all over the world. And China has made the most progress in terms of satellite transfer because they have regional centers. Unlike US, only certain centers can do tertiary care levels, and they have shown that a lot of these babies have been saved. Even in US, there are tons of papers where it shows midwives have delivered, they've diagnosed the disease and transferred the baby, in the boondocks of Kentucky or West Virginia, places like that if you ever practice, even in Louisiana. So you have to decide, do I want to ship this kid out or not? If that pulse oximeter is low, it's better to be shipped out because some heart diseases get worse with time, right? So it's very important, especially if it's a term or a near term.
Any other questions, comments? I think the presentation was clear. Okay, thank you so much.